As many of you know, my family and I lost our health and our home in a battle with toxic mold exposure. As a result, I've been working diligently on a documentary film about mold toxicity. You can learn more about this project at moldjacked.com. As part of this project, I recently had the pleasure and privilege of interviewing Dr. Neil Nathan. It is rare to come across a doctor whose passion matches his experience. Dr. Nathan fits that description perfectly. He's been practicing medicine for over 50 years. He's board certified in family practice and in pain management. He's a founding diplomate of the American Board of Integrative Medicine and of the ISEAI. He has worn many hats in his long career: clinician, author, radio show host, and teacher. He's on a mission to help spread information about mold-related illness. And tonight, I'm releasing our interview in hopes that you might find hope, wisdom, and guidance on your journey to better health. Enjoy. You unlock this door with the key of compassion. Beyond it is another world, a world of science, a world of common sense, a world of sanity. You're moving into a land of both empathy and ethics, of nutritional knowledge and empowerment. You've just crossed over into Dr. Osborne's zone. Dr. Nathan, thank you so much for joining me today. I really appreciate you taking the time out of your busy schedule to shed some light on mold-related illness.
Thanks for having me.
I'd like to know, you're a medical doctor, what got you into this field around mold? Was it patients? Did you have a mold background story yourself?
I didn't. A lot of the physicians who get into this field have themselves or a family member sick, and they kind of realize it's something they need to wrap their head around. I think the start of my story is, for many years I've been a pain specialist. And in the middle 80s, we started seeing an odd condition which we called then fibrositis. Now it's called fibromyalgia. And it didn't look like anything we'd ever seen before. And since I was at the time a pain specialist, what most people do with something new is decide that it's psychological until proven otherwise. But people got all kinds of medications and they got psychotherapy, and it didn't help them one bit. So it was clear that it was not a psychological illness. It was a physical illness, and we didn't know the pieces. Over the next couple of decades, we began to learn that it was related to hormonal imbalance, magnesium deficiency, gut dysbiosis, food allergy, and then we began to realize that Lyme disease and later mold toxicity were major players in what was causing fibromyalgia and chronic fatigue syndrome. So I came in that door, in which when we first started learning about this, for me, in 2005, I had a patient who came into my office and plopped Richie Shoemaker's book, Mold Warriors, which had just come out, on my desk, and said, I want you to read this. I said, great. I put it up on my desk with bunches of other books. I have a stack of books. She said, no, you don't understand. I want you to read this right now. So I said, great. You're going to pay me for reading a book? Fabulous. This is a wonderful job. Fortunately, early on in the book, Dr. Shoemaker had laid out what he called the biotoxin pathway, which was a brilliant understanding of how mold toxicity triggered all of these disparate symptoms, and he put it together in a package that I really understood. And so literally, I went out to where he lives in Pocomoke, Maryland, and spent a week with him and studied with him and realized this is a big deal. We're missing something here. I immediately had, I was dealing with a lot of chronic fatigue and fibromyalgia and people who had all kinds of symptoms that my colleagues couldn't figure out. And all of a sudden, we had a way to diagnose it and treat it that not only made sense, we were able to help countless patients who had been languishing with no diagnosis and no clear treatment plan. And now we could. And that evolved. From Dr. Shoemaker's work, we worked together for a while, and then we have different approaches now. I felt like we needed to incorporate more and more of the research that was being done and the information that we were acquiring and create the most comprehensive treatment program possible. That's kind of what I feel like I've been doing. So that's kind of how I got here. And now we're able to help many of the literally millions of people in this country who are suffering with mold toxicity.
So millions, what would you say in your estimation or in the research's estimation is the scope of mold-related illness? Like what kind of numbers are we talking?
Uh,
Households, people?
most people are talking 10 million Americans right at this minute have mold toxicity, and most are not aware of it and they've never heard of it.
And so how would those patients manifest? You mentioned fibromyalgia earlier, but are there common clusters beyond that that you see clinically in these people?
Sure, there are. Um, any condition that a specialist diagnoses as atypical. What we'll often see, people will be told they have atypical rheumatoid arthritis, or atypical multiple sclerosis, or atypical Alzheimer's, or atypical Parkinson's disease. Whenever you hear the word atypical, almost always that means it looks a little like that, so that the specialist isn't comfortable saying, yes, it is. These are almost always either mold toxicity or Lyme disease.
Okay. So atypical is the kind of the buzzword that the patient needs to kind of,
It's a word. As I mentioned, chronic fatigue and fibromyalgia. Dr. Joe Brewer did a study 2013 where he took 112 patients with chronic fatigue and fibromyalgia, and he discovered that 92% of them had mold toxicity. And in proof of that, when he treated them, the vast majority got well. So we're talking about an illness that other medical people say is not treatable. We don't have a cure for it. And actually, we do know what's causing it in many patients, and we can cure it. Um, Patients who've been told that they had asthma, but they're not responding to the normal treatments, will often have mold toxicity. Neurodegenerative diseases, again, Alzheimer's, Parkinson's, ALS, are often a manifestation of mold toxicity, unusual neurological ways of presenting. Children on the autism spectrum, many of them have mold toxicity. So it's kind of what we call a great masquerader. It has so many different ways of manifesting in the body that if you're not familiar with it, you might look at someone and go, nobody could have that many symptoms. But the symptoms are caused by inflammation triggered by mold toxins. And that inflammation is systemic, it's global. And so wherever someone has a weak system, biochemically or genetically, it's going to manifest as a form of inflammation. And so neurologically, it can manifest, as we said, with Alzheimer's or Parkinson's. It can manifest as a peripheral neuropathy. In the lung area, it could manifest as asthma, shortness of breath, chest pain. Cardiovascularly, we'll see palpitations and arrhythmia. In the GI tract, almost any GI symptom can be a manifestation. Gas, bloating, distension, diarrhea, constipation, abdominal pain, reflux. Um, and global symptoms, fatigue, cognitive impairment are big. For example, Dale Bredesen has been doing groundbreaking work in showing that Alzheimer's disease is an inflammatory process that affects the brain. If you can figure out what parts of inflammation are doing it, you can actually cure or markedly improve people with Alzheimer's disease. And one of his findings is that mold toxicity is present in most of them. So again, very often missed in that situation.
I mean, that sounds really rather alarming because you mentioned a lot of the conditions you just mentioned are quite prevalent. And
Oh, yeah, absolutely. Psychological conditions, very, very common in mold toxicity, anxiety, panic, depression, depersonalization, derealization, obsessive compulsive disorder, very, very common. So almost any symptom you can think of is being triggered by the inflammation triggered by mold toxicity. And I don't want this to be alarming, rather empowering, in that if someone has a lot of symptoms that have not been explained by going to your family doctor or internist or wherever you're going to see, and they're basically scratching their head and saying, I don't know what could be doing this, then basically mold toxicity and Lyme disease are the two most common conditions that are being missed.
Can you differentiate the difference? You're using, I think, specific language, mold toxicity versus mold exposure, mold allergy. Can you parse those differences? Because a lot of people that I have seen in my clinical practice, as well as others I've talked to, are told there's a mold allergy problem, but if you're not allergic to mold, then it's, if you don't have the coughing, the sneezing, the wheezing, that type of symptom profile, then you probably don't have mold exposure. But could you parse those differences?
Yeah, sure. So in medicine, we've known about mold allergy forever. That's not a new concept. We've known that a rare patient will get a mold infection, which is a kind of a life-threatening illness which requires antibiotics. That's rare, and that's not what we're talking about. We're talking about the fact that molds make mycotoxins, which are mold toxins, and those mycotoxins will affect the body by creating a generalized inflammatory condition. And so this is not mold allergy, although they can coexist. You can be both allergic and toxic to the mold. So mold toxicity is a kind of it's not a new concept. It's written about in the Bible, but it's not been appreciated in the medical field until now. And even now, it's still not really known much about it or understood.
Why do you think that is? I mean, what is there a lack of formal training in medicine? Is it just people don't want to wake up and see that, that mold might be more prevalent and we actually have to do something about it, be even beyond medicine, like with construction and building and other.
Those are two separate areas of denial. There's denial on the part of the building industry, where it's estimated by many experts that up to 50% of all homes in this country have an appreciable amount of mold in them. So this is not a rare experience here in this country or anywhere. Um, but there's denial on the part of the medical profession. And what I've experienced, Peter, is medicine is very quick to embrace new medications and new technology. That's because there's a huge economic driving force behind it. Medicine is really slow, and the history of medicine, history of science, is that new concepts are not embraced immediately. There's this kind of reluctance, which is, well, you're going to have to prove it. I need to see enough written in peer-reviewed medical journals. I need to have proof of science before I take my precious time and study something that I never heard of before. And that's gone on forever. Any new concept in medicine takes a while for our profession to embrace it. It just does. Um, Maybe that's a fail-safe. Maybe that's good, and that we don't embrace every cockamamie new concept that comes down the pike. On the other hand, um, some of us have been in this field for 20, 30 years, and I've personally helped 4 or 5,000 people get well from mold toxicity. So in my world, this is not a new concept. This is very real. This is what I help people with all day long. And it's frustrating for me and for my patients to not have the field embrace it. So if you go to most physicians as a patient and you present with these complex symptoms that cover the whole highway, it's more likely than not that someone will either honestly tell you, I don't know what's going on here, or they'll refer you to a specialist for a piece of it. So if you have joint pain, muscle pain, which is common in mold toxicity, you might see a rheumatologist. You might see a pulmonologist for the respiratory issues. You might see a cardiologist for the cardiovascular issues or a neurologist. And so it's that classical story of the blind man and the elephant, where in a specialist field, each sees a little piece of it. And not a lot of people are putting it together as asking the question of, okay, what physiologically could cause anyone to have that many symptoms? And the simple answer is inflammation. And I think as a field, medicine is beginning to embrace inflammation as an underlying component of almost all chronic illness, but just beginning. I mean, and there are peer-reviewed papers that have been out for the last 6, 7 years where that's literally the title of the paper, Inflammation as a Cause of Almost All Chronic Illness, written by academics, peer-reviewed, but that information isn't trickling into the people on the front lines.
What would your advice be to a patient who maybe suspects they're in mold? What kind of doctor should they seek out? Is there a particular, postgraduate training or a website, a database that they could go to find a mold literate doctor?
It's difficult. There's no certification process for a field that medicine doesn't quite recognize yet. That's down the road. I have on my website a listing of physicians that I've trained. So people all over the country and world certainly are listed there. So patients can go to my website, which is just neilnathanmd.com, and look for medical practitioners. People I've worked with enough that I know that they know what they're doing. As a general concept, physicians who specialize in integrative medicine or functional medicine are the kinds of physicians you would want to work with. But not all integrative or functional doctors are familiar with mold toxicity per se. So that's a starting point, but you need to find someone who actually has some experience in this field because it's complicated. When people do have mold toxicity, it's not a simple treatment where here, take this for a week and you'll be well. This typically takes a year or more of complicated treatment to get people well. But my take-home message, which I really want to leave people with, is it is treatable. We can get the vast majority of the people we work with well.
What what types of tools are you using clinically with your patients to help understand whether or not they're in mold? As you've mentioned, inflammation is a driver for a lot of conditions, and there's a lot of reasons people might have inflammation, but are there specific biomarkers or tests that give you greater insight or help you rule in or out mold?
I think the best test, most specific test, is a urine mycotoxin test, which very simply a patient collects their first morning urine and it goes off to the lab and be analyzed for the presence of mycotoxins. If there are mycotoxins in your urine, it's in your body. It's coming from somewhere. So that is, for me, the most simple, easy, direct way to know that there are mycotoxins in the body. And I then know which mycotoxins are in that body because we do use binders to get mycotoxins out of the body, and the different mycotoxins are bound differently. So, for example, if you had ochratoxin in your body, which is a common one, then cholestyramine, Welchol, which are both medications, or activated charcoal are the best binders for that. And down the line, each mycotoxin has specific binders that will help pull it out of the body. So that's urine mycotoxin testing to answer that question is, for me, the number one test to do. There are some biomarkers, but they're not as specific as we need them to be for mold. For example, when people talk inflammation in medicine, that generally means we check a SED rate or a C-reactive protein. Those are the most common tests we use. That won't show up mold toxicity. For whatever reason, the kind of inflammation that's triggered isn't reflected in those tests. So again, If a patient goes to a physician and they've got joint pain and muscle pain and they say, I'm inflamed, and they check those tests, they'll come back, well, no, you're not inflamed because those tests are normal, not the right tests. So other tests have been discovered. Dr. Shoemaker uses TGF beta 1, C4A, and MMP9 as three tests which really will reflect the presence of mold toxicity. However, it will reflect the toxicity or inflammation of Lyme disease and several other inflammatory materials. So it's not specific for mold, but if it comes back high, it will certainly raise the suspicion of, okay, what's making that TGF beta 1 go up to that extent? It's a real condition. We're not talking psychological here. Something is driving that. And then you need to still go back to the drawing board and get a urine test to go, okay, is it urine or do I need to do a Lyme test to figure out is it Lyme disease? But those markers are helpful. Most recently, I've gotten excited about Bruce Patterson's Radiance Lab, which measures 14 different cytokines in the body as a cytokine panel. And he's discovering that there's a different inflammatory cytokine pattern for long haul COVID and for Lyme disease. So you literally can tell, okay, this pattern reflects long haul COVID and we can treat that. This reflects Lyme disease. And we've just started working on mold, and there is a different pattern for mold. So although we're just in the beginning phases of doing that research and getting it published, but we are, I think shortly, that test will be a great way to be able to tell what kind of inflammation is going on. And we can then narrow our focus on, okay, this is most likely to be mold with this pattern, or this is more likely to be Lyme with this pattern. So we have some markers, but they're helpful in letting patients know it's not in your head. This is real. But you kind of need to know that the markers are not as specific as we need them to be.
So in your opinion, then mycotoxins the most direct evidence of exposure, and then inflammatory markers, non-specific, but clues, breadcrumbs to the road of, potential mold.
Yeah,
Do you ever find that, or do you rule out or try to rule out like food components to mycotoxins? Like some foods can be contaminated, like coffee, for example, with ochratoxin A. When you have your patients collect their urine mycotoxin testing, do you have them change their diet for a period of time prior collection?
I don't. I know that some people are writing that most of what you see in the urine comes from food. That is not my experience, and it's not the experience of the vast majority of people who work in this field. The vast majority of mold toxicity that I see comes from inhaled spores from water-damaged buildings. Um, the, the government agencies do a fairly good job of checking food. So there's trivial amounts of mold or mold toxin in some foods. We know that. Occasionally, there'll be actually epidemic outbreaks of mold toxicity from food. For example, a silo that has a moldy grain or moldy peanuts, then you'll get a whole community that will come down with mold toxicity from food. We know that that exists. That's rare in my experience. Um, I did a short pilot project study with Great Plains Lab several years ago, in which it's a small study, but we took 8 patients with mold toxicity. It's not big enough to be statistically significant, but we had them avoid all known moldy foods for 10 days, and we checked a urine test on them. Then we had them pig out on those supposedly moldy foods for 10 days and repeated checking for urine mycotoxins. 7 of the 8 patients surprisingly had lower mold toxin levels in their body eating supposedly moldy food, potentially moldy food. 1 had a slight rise in ochratoxin. So to my knowledge, there's no other studies that have been done on this to really answer that question. But I don't think food is a major player here.
Okay. Yeah, I mean, I've heard that side of the argument from different people. Thank you for your take. It just, yeah, I tend to agree with it. I've seen a case, a couple actually, where one was a gentleman who would drink a pot of coffee at work every day, and it was a community coffee pot, and probably had mold in the water chamber. But his ochratoxin A came back over 70, and it was real-time labs, and so we got him to stop the coffee. And that's really the only time I've ever seen a major case of food contamination.
Well,
Drink.
it can. Um, the one food that I'm aware of that's not monitored is coffee. The government, for some reason, does not have any part in measuring mycotoxin levels in coffee, and so like bulletproof coffee came about, and now there's dozens of other mold-free coffees because that is one area where you can get some appreciable amount of toxin from food. I mean, you can also get it from blue cheese, for example, which is penicillium. It is mold. So there's a few foods that I don't want to be global in saying food doesn't have it, but I'm saying that the vast majority of what people eat doesn't have a significant amount of mold in it.
Okay. So we've got mycotoxin as a best biomarker for direct evidence of exposure. When you find somebody with that at elevated levels, kind of what are your next steps or advice for them?
Well, from my perspective, curing or treating mold toxicity is a three-step process. First, we need to evaluate the patient's home and work for if they're being exposed. If they are, no matter what we do, they're not going to get well. And that's one thing that I think everyone in the mold field agrees on. Um, um, there are different schools of thought about the right way to treat it, et cetera. But one thing we all agree on is you can't get well if you're being exposed to mold ongoing. Can't happen. So we need to test the home and work for the presence of mold species so that we can either remediate it or let the folks know you're going to need to leave this place. You need to get out. You won't get well otherwise. That's one step. Second, you need to take binders that are specific for the mycotoxins that we're seeing in their urine. And we now pretty much know how to do that. Third, many, if not most people who've been exposed to mold have been exposed long enough that they've colonized, meaning that mold is now growing in their sinus or gut areas or both, and antifungals are going to be necessary so that it gets out of their body. So those are the three main components of treatment.
So let's start with number one. When you're referring them out to have inspections done, could you comment to how should somebody screen for a mold inspector? Because a lot of the industry is, air test centric. What kind of tips or guidance could you give our audience in terms of, what not to do? What are the big no-nos when it comes to hiring a mold inspector?
Well, unfortunately, depending on the state, you can be a licensed mold inspector with 10 hours of training. And that is not adequate to know what you're doing. It's not. And as you said, and I'm glad you referred to it, most mold inspectors use as their primary tool air sampling. Now, air sampling is intrinsically flawed. In air sampling, you're sucking the air out of the middle of a room and measuring the kinds of molds and the number of spores in that air sample. Well, that's nice, but all mold spores are heavier than air. They're not sitting in the middle of the room. They're on the floor. So it's not sampling what's really there. And way too many people have been told, oh, we've sampled the air and your place is fine, when in point of fact, it's very toxic to them and they're not looking in the right place for it. So first, don't use air sampling as your primary way of knowing if your home is safe. And then, experts disagree on this, but in my experience, ERMI testing, in which we're testing the dust present in a home, is the most accurate way to know whether or not a home is safe. And personally, I use a two-step process to help patients understand where the mold might be, first crudely and then honing in with ERMI testing. So I typically use mold plate testing so that we can put a mold plate in every room in the house, which would include a crawl space, basement, attic, garage, and then with the mold plate, which is just a petri dish that grows mold, you leave it open to air on the floor for 2 hours with some air circulation going on, put the top back on, and you see what grows. If something is growing, you need to get it analyzed so know what you're looking at, because non-toxic mold species will grow on the plate just as well as toxic. So just because you have an ugly looking plate doesn't mean you have a problem. So if you get it analyzed and you see that there's a significant number of toxic mold species on that plate, you know that you have a potential problem in that room. So I like to do that for the whole house. And if there are specific rooms that light up with mold toxin, in those rooms, I'll do ERMI so we can save people money, collecting dust from those rooms and getting it analyzed. That's to me a starting point. If those tests clearly show mold toxicity, then I'll bring in an IEP to an environmental inspector who can do it. And as you're pointing out, that's potentially tricky. Not all IEPs are created equal. Some have been years of experience and they're really good at it, and others you really don't have a clue what they're doing. And you could spend a lot of money on it. Um, one of my comments to uh, consumers would be find an inspector who is not also going to do the remediation so that that person doesn't have a vested interest in saying, oh, we've got a $50,000 remediation project here, which would be self-serving for that person. You want to have someone who has a clean look. I'm just telling you what's in your house. This is what you have. And then, and here's a list of people you could go to who are good at remediation, because that's another can of worms.
Yeah, for sure. I know I had a case in California. I think it cost her 15,000. The same inspector was the remediator, and anyway, once they took her money, they were gone. She never heard from them again, and of course, they didn't do a very good job. So you can get burned pretty bad by shysters that are out there looking
You,
to
you
make.
can. There's a website for the organization ICI, the International Society for Environmentally Acquired Illness, that has a website that lists mold inspectors that are at least part of that organization. That's not a testimony that they're all perfect or excellent, but that's a good place to start.
Okay. ISEIA.
ISEAI.
EAI. Okay.
Yes.
EAI. Okay.
Okay.
So that's step one is just finding somebody qualified to help you find the source of the mold so that you know how to properly get a remediation of the mold. And then step number two, you said were binders. Are there other aspects of treatment that you like? Do you start treatment if somebody's still in mold, or you wait for the remediation to start first? What is your approach in that regard?
While it's absolutely true that you can't get well in a moldy environment, you can get a little better. And I hate leaving people high and dry with, I'm sorry, there's nothing we can do until you get it to a safe environment. I can't do that. I want people to at least be um, not getting worse by at least beginning to take the binders that they need to get going on minimizing that. They can use HEPA filters to decrease it. HEPA filters are imperfect. They won't completely get rid of either mold spores or mycotoxins from any given room, but they help. And not everybody can move instantly. It's financially, socially, economically difficult. So while it's absolutely necessary that they get into a safe environment, one of the hardest part of mold treatment is helping someone to be supported until they are able to get themselves into a safer environment. And that's really hard.
Yeah. So what you use binders? Do you use other things? I mean, are there other like things that you find to be necessary, like things for liver detoxification or
It,
glutathione?
it all depends on the person. Um, in my, from my perspective, which is a little different than others, um, you can you can spend a lot of time detoxifying someone, and I think that is delaying what's really necessary. What I mean by that is I've had a lot of patients have come to me who've spent 6 months or a year just improving their ability to detoxify. That's fine, but what's keeping them from being able to detoxify is the mold toxicity. So I think they're putting the cart a little bit before the horse. The number one thing that a patient with mold toxicity needs to do is to get that toxin out of their body. So my emphasis has been on removing the toxin. Some patients need help with detoxification to do that, and that might mean taking supplements like milk thistle or alpha lipoic acid for the liver, TUDCA to help gallbladder function better, or bitters, working on the biome to a certain extent. But I want to emphasize that one of the hallmarks of functional medicine is treat the treat the gut first, get the biome first, everything else will follow. The exception to that is mold toxicity, which usually has candida. You can spend 4 years trying to get the gut fixed, and if you're not getting the mold and candida out of there, those treatments are not going to work. So I think it's important that people recognize that getting the mold out is job one. And yes, there's many other things you can do. There are homeopathics that I use, there's herbals that I use. I like intravenous phosphatidylcholine as a way to help do this as well. But if we lose sight of the key, which is you've got to get the toxin out of there, working around it is nowhere near as effective as you want it to be.
You mentioned candida in the gut. Um, what do you find? Because I see the same thing that you were talking about there. I mean, it's probably one of the most 90% plus that I see in mold cases. What are you finding successful for that aspect? Do you have them take antifungals? Do you have them take herbals? What kind of tools do you find work best?
I do, and I have the same observation, Peter. I would say at least 90% of my mold patients have candida also. So same observation. And a quick hint to clinicians in that category is if you're seeing gliotoxin and your mycotoxin test, gliotoxin is made by candida. So once that lights up, you're literally being told, yes, there's candida here also. And candida is notoriously difficult to test for. Our tests, we have some, but they're not as accurate as we need them to be. So to answer your question, when I have candida on board, typically I will use nystatin, um, working up to a million units twice a day. I may add diflucan to that, and I may pulse the diflucan as one of the first things I do to start treating it. One of the binders I use that will also treat candida is Saccharomyces boulardii. And that is not only an excellent binder for gliotoxin and zearalenone, by the way, but it helps to flood the GI tract with a benign fungus species and kind of push mold and candida out. And we've used it in that context for decades already. But the newer finding is that the cell wall of Saccharomyces specifically binds gliotoxin and zearalenone. So it's got a double benefit. So that is what I would do for Candida. And I would then add a biofilm dissolving agent to that once it's on board. There's a number out there on the market which I like. And then I would layer on top of that an antifungal, where itraconazole would be my number one, and I've got others that I'll use.
Okay. In treatment for, if somebody's out of the mold, we're trying to get the candida out of them. What kind of time frame do you typically see? I know it's different. I know it can vary, but in your
It's
patient population.
it's much longer than most physicians think. I've been working with Candida for 40 years. Um, a lot of physicians think that it goes away with a 7 to 10 day course of diflucan, and in my patients, it doesn't work that way. Often 6 months to a year is necessary of taking antifungals to really get it out of the body. The endpoint for me is urine mycotoxin testing, where when that one comes back not present in every category, then I'm really comfortable that we've gotten the mold and candida out to the point that the immune system can reboot itself and now do its job properly and keep that patient much more protected.
Okay. So we've talked now, I think, in good detail about step one, which is identify the mold and get an inspector. Step two, which is treatment. Let's go into step three.
Okay. Well,
Uh,
step three we've been kind of been talking about, which is adding the antifungals. Um,
the decolonization as a whole. Now, candida for the gut. What do you do cultures of the sinus cavities? You'd mentioned earlier that that a lot of people's sinuses can get colonized as well as their gut.
they can, but I think it's more a clinical diagnosis than a. It's very hard to get cultures accurately. The ENT profession has known for decades that the yield on culturing a known fungus from a sinus is less than 10%. So a normal culture is rarely going to show you anything. More recently, and it's really new, MicroGen DX has some PCR technology where we can go into the sinuses and get a better idea of what's in there. That's adding to what we have been able to do in the past. Um, but often, especially if a patient has sinus symptoms, and if they have a CT or an X-ray of their sinuses showing mucosal swelling, it's a pretty good bet that they have some degree of fungal or candida affecting those sinuses and need treatment. I mean, the Mayo Clinic discovered that back in 1999 when they published their studies about how people with chronic sinus conditions which had not responded to antibiotics were responding to amphotericin B as a nasal spray. So now there's an interesting question in there, and I've recently been talking to some experts about this. In the Mayo Clinic study, their perception was it was an allergy from the fungus that was creating the chronic swelling in the sinuses, and that the amphotericin B was killing the fungus, so it wasn't setting off the allergy. My perception is it's twofold. Yes, that happens, but I think there is a direct toxicity of mycotoxins on the sinus mucosa, and that by doing this treatment, it's even more effective than what the Mayo Clinic found 25 years ago. Back then, they didn't know about biofilm. So one of the things we've learned that's a big addition to treatment is that both candida and mold make a lot of biofilm in which the mold and candida hide, protected from both the immune system and the effect of antifungals. So using using biofilm dissolving agents is an integral part of what we need to be doing to get it out of the body.
Okay, what do you find there? Do you proteolytic enzymes, EDTA? What do you find the most effective?
I find EDTA the most effective material on the market, and that's the one I use the most. Um, a product that I like is Interphase Plus, which is EDTA orally. And when I use nasal sprays, I'll have the compounding pharmacies put EDTA in the nasal spray to get it out. Some of my colleagues like NAC, which has some dissolving action on biofilm, and then things like nattokinase, lumbrokinase, seropeptidase. A lot of my colleagues like that as well.
What are your opinions on, so we talk about mold colonization or candidal colonization, but what are your opinions on like gram-negative bacteria, also present in water damage building materials? Are you seeing a lot of bacterial colonization in
Um,
patients as well?
right. One of Dr. Shoemaker's early findings was that Marcons, which is this gram-negative bacteria that I think you're talking about, he felt that that was an important component of treatment. Again, I worked with him early on, and I never found that you could really clear Marcons at all. And over the years, he later admitted that Marcons is not a pathogen per se, but really a commensal. It basically lives in the sinuses, and you can do almost anything you want to do, and you're not going to get it out of there. So my experience has been that's not a player. And I would say that the majority of people who work in this field have come to the same conclusion that measuring that or treating that specifically hasn't really helped people to any significant degree. So no, I don't even measure it anymore.
I came to that conclusion probably 7 or 8 years ago myself. I was also, though, referring to colonization of the GI tract by things like Citrobacter or Klebsiella or Pseudomonas. I don't know. I just asking what your experience
Yeah.
and opinions.
Again, to me, that falls into the category of treating intestinal dysbiosis. And I think there's a sequential process here. In my experience, you've got to get the mold and candida out first. Then, if you have Proteus or Klebsiella or Enterobacter, then the things that you typically use to treat it with work infinitely better. If you try to get it out before you get the mold out, you're going to be spinning your wheels.
Okay. So identify the mold, the source, bind the mold out of the body or the toxins of the mold out of the body, treat the colonization of the body. You go through those three steps, a year, 2 years, somewhere in that neighborhood is kind of a realistic expectation on the patient's end.
Yeah, if this is a big if the patient is able to get out of their moldy environment and remediate it, I tell people that a year is a reasonable period of time to get well in. And in honesty, a lot of people take longer than that. They might take a couple of years. But the vast majority of my patients will get well if they're not in a moldy environment, if they take their binders and they take their antifungals. The There's a caveat or exception to that, which is my patient population over the years has become ultra sensitive. That mold toxicity will trigger in many patients if it stays long enough, if it's not being diagnosed, if it's not being treated, it will trigger limbic dysfunction, vagal nerve dysfunction, and mast cell activation. And the majority of my patients have those. Those may need to be treated first for their body to be able to respond to binders and antifungals. And so to me, that's a huge step that not everybody appreciates yet.
Would you say those are kind of more the people that have been in it for a very prolonged period of time? Um,
Yeah, it depends on their immune system. The more robust an immune system is, the more it can tolerate being in a toxic environment for a long period of time. Um, if the immune system takes a hit, then it loses containment, and then you become way more sensitive much more quickly. You can take a hit I mean, COVID was a biggie for getting people to lose containment, but any infection, any flu, a surgical procedure, or a major psychological loss of any kind, um, childbirth, any of those major stressors on the body can weaken the immune system, and then the effect of the mycotoxins become much more profound.
so basically amplified. amplified effects. With MCAS, do you find do you use antihistamines? Do you use DAO? What kinds of tools are you finding
Uh,
helpful?
Yeah, MCAS is a very complicated process. We know that the activated mast cells can release over 1,000 biochemical mediators into the system. And so taking a single agent to try to control MCAS, I don't think works very well. So my approach is to come at it from as many different directions as I can in a kind of like a package. So that would include H1 and H2 receptor blockers. It would include mast cell stabilizers. It would include DEA. It would include a material called All Clear, which is a tryptase inhibitor. It would include PEA products like Merica. You need to come at it multifactorially to get it under control.
So your patient pop, you would say yours is a little biased, and that's who you're ending up with. That's just kind of who's walking through the doors.
Uh, Very few people walk through my doors and haven't for years. When I started, I saw people who weren't that sick, but I got involved early on in the field, so people began to refer their sickest patients to me, and that became literally my whole practice. The I would say at least 70% of my patients have mast cell activation, and 80 to 90% have limbic and vagal dysfunction that need to be treated early on. But that's a skewed practice. I readily admit that.
Okay. Yeah, yeah, biased of its own right. Um, what's the big takeaway, that you would say anybody watching this show should absolutely walk away with understanding that would be important that they wouldn't get or hear from someone else?
Okay, I'll give you several. Number one, mold toxicity is really common. It is not rare. Number two, if you have a host of symptoms and you're not getting the help you need from conventional medicine, seek additional help in this field. Think about mold toxicity as a primary issue. But those would be my two biggest takeaways, which is we can cure this. The vast majority of people with mold toxicity will get better if we have the correct diagnosis and we're treating them in the proper way. And for me, the proper way that I sometimes see is people do kind of a half-hearted job of doing treatment. So instead of taking what I will call comprehensive binders, meaning a binder for every single toxin that's there, so we really get them, they'll just put them on charcoal or just clay or a combination of it. They're not really getting binding activity on all of the toxins that are there. Another issue that I see is um, I don't think that you should be taking antifungals until binders are fully up and running, or you're going to risk a serious die-off reaction. So I have a bias that some physicians who hear about this throw people on Sporanox immediately when they make the diagnosis, and that will make people, many of them, really sick. So do this in the proper order, in the proper steps, slowly and gradually. Another common issue that I see is people will use stronger doses of binders than a patient can tolerate. If you take too much binder, it will mobilize toxin faster than a patient can process it, and they'll get worse. So another biggie is people getting worse on binders and some physicians not understanding what's going on and saying, oh, you need more, which is absolutely the wrong direction to go in. So I think what I would tell patients is if you're not getting better with whoever's treating you, find someone who knows more about this and get the kind of help you need. It is out there.
Fantastic. Well, Dr. Nathan, I really do appreciate your time today and your expertise and your commitment to excellence and helping people and also training and educating doctors. It's very necessary and needed, and you're very appreciated.
Thank you.
It was wonderful talking with you, and I wish you the best.
Yeah, yeah, same.
Thanks.
Thanks for tuning in to the Dr. Osborne Zone. Don't forget to share, like, and subscribe for more content like this, and make sure you come back next Tuesday at 6 p.m. Central Standard Time and Thursday at noon 30 for more episodes.